Thank you, everyone, for joining us today, spending some time with us. I'd like to introduce you to our host of the webinar today, Dr. Lloyd. She is the Sanford Guide Antimicrobial Stewardship Program Manager, and she's going to walk us through this webinar that we have for you this morning. And I don't want to take up any more of our time, so we're going to jump right in, and she's going to lead from here on out.
Thank you, Andrew, and good day to everybody. I'm so happy that you could join us for this conversation about revitalizing your hospital stewardship program. I'm hopeful that for those of you that have existing programs, you can take away some ideas to take back to your program for 2025. And for those of you that maybe are just getting started or need to optimize your program, I hope that you too can take some nuggets of information back with you from today's presentation. But my challenge for everyone is we're going to talk about 3 priorities, but I hope that if nothing else, you can take one thing back to your program to make 2025 better for you. Like many of you, we are observing U.S. Antibiotic Awareness Week this week. The theme for U.S. Antibiotic Awareness Week is Fighting Antimicrobial Resistance Takes All of Us. This is being held in conjunction with World Antimicrobial Resistance Awareness Week, and the theme for that is Educate, Advocate, and Act Now. But it's not just the US and it's not just the World Health Organization. There are a lot of folks across the globe who are participating in this effort to get out the word about antibiotic use and antibiotic resistance. And so the European Antibiotic Awareness Day was on November 18th. And one thing I loved about their messaging was their hashtag of Keep Antibiotics Working. I think that's a really simple slogan that is helpful for everyone to understand. Additionally, Australia is observing Antimicrobial Awareness Week this week as well. And one of their key points is that antibiotic resistance is happening now. So bringing that awareness that this is something that's happening now that we need to be working on. And lastly, Canada is also observing Antimicrobial Awareness Week. And one of their key messages is building antimicrobial resistance awareness together, which mirrors a little bit of what the US CDC's message is around this week. Regardless of where you are across the globe, we hope you're all participating and getting the word out about antibiotic use and antibiotic awareness. The World Health Organization encourages everyone to go blue for this week, and so I'm wearing blue in support of that, mostly because I don't have a purple shirt, but I do have my purple pen, which is the CDC's recommendation to go purple for antibiotic awareness. So if nothing else, take some of those key messages with you back to your facilities. The objectives for today's presentation are listed here on the slide for you. I won't read through them for the sake of time, but we will be covering these points throughout the course of the presentation. I think more helpful is the agenda and what we're going to cover today. So I hope to convince you that fighting antimicrobial resistance takes all of us. I'm going to share with you some data from around the world about why this is so important and why the work that all of us do as antimicrobial stewards is helpful in this fight against antimicrobial resistance. Then we're going to hone in on these 3 priorities for 2025, and I'm going to encourage you to find your focus, to get back to the basics, and to embrace technology, or if you're in a technology limited area, enlist the help of your friends. Then we'll summarize and again, leave time at the end for questions and answers. So I would love to leverage the CDC message of fighting antimicrobial resistance takes all of us to again set the stage for why the work that we do as antimicrobial stewards is so important and why it's so necessary. And nothing is more fitting than the fact that today's theme for November 20th for the US Antibiotic Awareness Week is human health and antimicrobial resistance. And associated with that theme are these key points on the right-hand side of the slide that we need to remember and to spread the word about to our patients and provider friends. Antimicrobial and antifungal use in people, animals, or plants contributes to antimicrobial resistance. Antibiotics and antifungals can cause side effects and contribute to antimicrobial resistance. And as we all know, antibiotics have been one of the most important medical advances in the last century, But when they become unavailable due to antibiotic resistance, some of the other medical advances that we've seen, such as solid organ transplants and joint replacement surgeries, can become more complicated. We need to help our patients learn more about antibiotic use and to remind them that antibiotics are not needed for viruses, that they need to talk to their healthcare providers about how to take their antibiotics appropriately and to discuss side effects. We can share patient education resources. The US CDC has a ton of great patient education resources available on their website, and they've done a lot of work to enhance those and update them. And then lastly, we should take a One Health approach. And that just is a collaborative effort across plants, animals, and people to make sure that we're all fighting this fight against antimicrobial resistance and supporting efforts to use antibiotics appropriately across all of those platforms. So let's take a dive down into some data. So the CDC most recently published antibiotic resistance threats in the United States in 2019. In July of 2024, they updated this information to share how we've progressed since 2019. And so in 2019, these infections on the slide were accounted for a 20% increase compared to pre-pandemic levels. And since in 2022, compared to 2019, we see increases in all of these infections except for MRSA. So what that tells us is that we still have a lot of work to do around these particular pathogens and in our hospitalized patients in the United States. Around antibiotic use, the CDC just released November 12th, the 2024 update on antibiotic use and antimicrobial stewardship in the United States. I encourage you to check out this page. The citation is at the bottom of this slide. And on this page, the CDC shares information about what they're doing to support antimicrobial stewardship and also gives us some information about antibiotic use data from across the United States. And important key points are that the outpatient antibiotic rate was 756 prescriptions per 1,000 population in 2023. Also in 2023, over 3,000 hospitals have submitted data to NHSN, or the National Healthcare Safety Network. So that's really great that we have so many hospitals contributing to that platform and sharing their data. As a part of that, when you submit your data to NHSN, you answer questions in the annual survey about your antimicrobial stewardship program. And while the increase in antimicrobial stewardship programs has been seen across the country with regulatory requirements to have programs and to meet the CDC core elements, the CDC updated the core elements and honed in on 6 priorities for antimicrobial stewardship programs. And in 2023, only 13% of hospitals met all 6 of those priority core elements. So I think that's one good place that we can go look for opportunities for our stewardship programs to increase the number of hospitals across the country that are meeting those 6 core priority elements. And then lastly, I would just share with you that if you're looking for more local data, I would encourage you to check out the Antimicrobial Resistance and Patient Safety Portal, where you can look at antibiotic stewardship data as well as antibiotic use data by regions or by states, and use that to compare antibiotic use at your facility to those across the country. What about outside of the United States? In collaboration with the European Antibiotic Awareness Day on November 18th, the European Center for Disease Control and Prevention released updated information about antibiotic resistance in the EU. And the good news is that MRSA bloodstream infections were nearly 18% lower in 2023 compared to 2019. And third-generation cephalosporin-resistant E. coli bloodstream infections were almost 4% lower in 2023 compared to 2019. The bad news is that carbapenem-resistant Klebsiella pneumoniae bloodstream infections were nearly 60% higher. Also increased were antimicrobial-resistant Kleb pneumo infections, vancomycin-resistant Enterococcus faecium infections, and then piptazo, ceftazidime, and carbapenem-resistant Pseudomonas infections. So while there were some good points there with some of the infections being lower, there was just a dramatic increase in those highly antibiotic resistant infections. And so there's a lot of work to be done in this area. Similarly, antibiotic consumption or antibiotic use data for 2023 coming out of the EU demonstrated that consumption had increased by 1% compared to 2019 at 20 defined daily doses per 1,000 inhabitants per day. And while this was not a statistically significant increase, it was still well above the goal for reductions in antibiotic use that they have targeted. Nearly 90% of that antibiotic use was happening in the community. And so that's an important opportunity perhaps to expand efforts out into the community. The most commonly prescribed agents were penicillins, macrolides, lincosamides, and streptogramins. Hospital antibiotic prescribing, again, accounted for the remainder of that consumption, and most commonly used agents were penicillins and then cephalosporins and other beta-lactams. So I've told you about the burden in the United States, and I've outlined a bit the burden in the EU, but antibiotic resistance is a global issue. It impacts all of us, and no matter where you're located, we can make a difference for our region or location. I'm sure many of you saw this foundational or fantastic data that came out of the Lancet in September, taking a comprehensive look at this global burden of antibiotic resistance. This was something conducted in something like 208 countries and regions around the world, and provided an estimate of this global burden of resistance along with a forecast for the future. And what you can see here is that in 2021, nearly 4.71 million deaths were associated with antibiotic resistance, with 1.14 million deaths attributable to that resistance. Over the course of the time period from 1990 to 2021, deaths increased by 50% for children less than deaths decreased by 50% for children less than 5 years of age, which is fantastic. But we saw an increase by over 80% for adults greater than or equal to 70 years of age. And then in terms of pathogens that are responsible for this global burden, Staph aureus is the pathogen that increased the most across the globe. In addition, and sort of mirroring some of that data that we saw coming out of the EU, is that resistance to carbapenems for gram-negative bacteria increased more than any other class. So where should we focus? The World Health Organization updated their priority pathogen list in May of this past year. And you can see on the left-hand side of this graph, those critical priority agents, including Acinetobacter, carbapenem-resistant organisms, third-generation cephalosporin-resistant Enterobacterales, carbapenem-resistant Enterobacterales, and then Mycobacterium tuberculosis, that's rifampin-resistant. So a lot of gram-negatives in that first bucket that we can definitely be focusing on. In the middle, you have your high priority pathogens, which is a little bit of a longer list, but includes that Staph aureus methicillin resistant at the bottom of the column, again, which is the one that we were seeing a lot of increase in that Lancet study. And then the last column is the medium priority pathogens. So these are the places where efforts are being honed to improve antibiotic use and antibiotic resistance. And then finally, what else is being done at the sort of global level around antimicrobial resistance? The United Nations hosted a high-level meeting on antimicrobial resistance on September 26, 2024. This meeting was last hosted in 2016, so it had been some time since this group had been convened. And what came out of this was a political declaration with a goal of reducing global deaths associated with antibiotic resistance by 10% by 2030, which is really not too far into the future. So it's a really lofty goal and one that we can all be a part of making happen. In addition to that, some prevention interventions were suggested. Those include immunizations, early and accurate detection of pathogens, infection prevention and control efforts, and then water, sanitation, and hygiene or WASH. And so this is great to have all of these, countries coming together and adopting this goal. in these recommendations, and I encourage you to check out the full content of those proceedings to understand more about what's being done sort of at that global level. So hopefully I have convinced you that we all need to continue to fight the fight against antimicrobial resistance. We need to work together to do that, and that can be across your facilities or across hospitals and health systems. But hopefully that data gives you some inspiration to continue to improve and advocate for your antimicrobial stewardship program. So let's next move into these 3 key priorities for 2025. Like I mentioned, those are going to be finding your focus, getting back to the basics, and embracing technology. So let's start with finding your focus. If you're like me, you might be interested in setting a resolution for 2025 and for your stewardship program specifically, and you might be thinking about all of the possible ideas that you could incorporate into your program. I just got back from ID week a couple of weeks ago, and I know I came out of there with a lot of great ideas for antimicrobial stewardship programs. It's almost overwhelming, the number of interventions that a program could implement. And so I challenge you to think about how and what those interventions might be for your facility. Do you look at facility-wide interventions, such as focusing on duration of therapy, transitions of care, perhaps implementing a culture review service? Or do you want to focus on a specific patient population? Perhaps you want to enhance your efforts in the emergency department because we know that's where antibiotics get started. Maybe you want to expand efforts into transplant or other immunocompromised patient populations. Perhaps you want to expand into pediatrics, or maybe even taking a deeper dive into a patient population such as sepsis. Whatever that is for you, I just encourage you again to set that goal and take it into 2025. But before you do that, you really need to establish what is your baseline. So I'm going to walk you through 4 different ideas for how you can find your focus and establish this baseline. We're going to talk about the Antimicrobial Stewardship Program Assessment Tool from the CDC. We're also going to talk about the Global Antibiotic Stewardship Evaluation Tool from the CDC. We're going to talk about point prevalence studies and then medication use evaluations. So first of all, coming out of the CDC is the ability to evaluate your program compared to the core elements of antimicrobial stewardship programs. When I was in practice, I loved to use this tool to find those gaps in my program and to identify opportunities. So take this opportunity to do a checkup for your program. On the screen here, I have screenshots of just the intervention or actions section of that core elements checkup. Of course, it encompasses all of the core elements, including your leadership commitment and your other components of those core elements. But just look at all of the great things that you can look at and ask yourself, are we doing this? So there's a lot of opportunities here that you can just get an idea from. Does your facility have specific interventions in place for patients with sepsis or patients with Staph aureus infections? Maybe that would trigger something for you and for your program that you want to work on and move forward with. So check out this checklist and check in to see where your program is and make it a priority to conduct this gap analysis at least annually so that you know what your opportunities might be. For those of you outside of the United States who may not be on the same trajectory with your program at this point in time, the CDC has released this new global assessment for antimicrobial stewardship programs. This is a 66-item questionnaire that includes 5 different domains, which are over on the right-hand side of the screen. You have your leadership commitment and accountability, your resources, education and training, your antibiotic stewardship actions, and then your tracking, monitoring, and reporting. You can complete this checklist or assessment online and use the scoring rubric to see how you score in each of these different areas, as well as overall. This was tested in 80 facilities across 12 different countries and is intended to be used, again, for global or non-US based antimicrobial stewardship programs. The really great thing about this tool is just how comprehensive it is, and also the ability for you to, again, identify those opportunities, perhaps implement an intervention, and then come back and complete this assessment to see how your score has changed over time. So it's not something you would do frequently because it is pretty extensive at 66 items, But again, maybe something that you want to do annually or after you have implemented a particular intervention or enhanced your program in some way. Perhaps you're farther along in the process and you really want to, I want to implement a specific patient population intervention. So I want to enhance antimicrobial stewardship in my pediatrics area. One thing you can do is to gather that baseline data is to conduct a point prevalence study. We are all very busy, and taking care of patients is usually the priority for most of you, as I'm sure. Making data collection a challenge. And continuous data collection can be even more challenging because you've got to get the right information out of your health record, or if you don't have electronic records, you're doing manual chart reviews to get this information. So point prevalence studies allow you to collect data at a specific point in time. Many times they're used across health systems and hospitals. On this day today, we're all going to gather antibiotic use data for every single patient in our hospital. But what I would point you to learn more about this type of study is the World Health Organization methodology for point prevalence studies, specifically on antibiotic use in hospitals. The really nice thing about this tool is that it gives you flexibility, particularly in resource-limited settings. And it gives you some data and information on how to conduct this study and what to consider. And then suggests that you should repeat this once every few years, again, to kind of see where you're at and to be tracking your antibiotic use and antimicrobial stewardship interventions. And then the last thing in this area of finding your focus that I want to talk about is medication use evaluations. And I'm sure for the pharmacists on the call today, you're very familiar with this, particularly if you've ever been a pharmacy student or a pharmacy resident, you may have participated in data collection for a medication use evaluation or a drug use evaluation. But what I want to call attention to here is the American Society of Health System Pharmacists guidelines on conducting medication use evaluations. It can be really helpful to take a systematic approach to conducting these MUEs. So taking that, again, systematic approach and involving all of the disciplines in your facility that might be a stakeholder in the area that you're looking at is a great way to optimize these medication use evaluations. So the steps that are listed here on the screen are from that ASHP document talking about finding the process to target for improvement, organizing your team, clarifying the current knowledge, understanding the causes of any variation, and then selecting your process improvement, and then doing a plan, do, check, and act cycle. So again, I would encourage you to check this out. I think it's a great way, again, to standardize that MUE process with the ultimate goal of optimizing patient outcomes. So that first priority that I'm challenging you to for 2025 is to find your focus. Do your brainstorming, get that list of ideas that you're excited about, and then go look in your data and find out where your opportunities are. Get that baseline so that you can implement your intervention and come back and reassess how well you have done at improving antibiotic use. So moving along to focus area number 2, I want you to go back to the basics or remember the basics. And so we're going to talk about some of the bread and butter antimicrobial stewardship interventions and how you might go about revitalizing your efforts in these areas and getting back to the basics and getting excited about some of those basic opportunities. So as a refresher, when the Infectious Diseases Society of America released their initial antimicrobial stewardship guidelines in 2007, these were the basic interventions that were suggested to be included in stewardship programs. Prospective audit with intervention and feedback and formulary restriction and pre-authorization were described as foundational to any antimicrobial stewardship program. Education, guidelines and clinical pathways, antimicrobial order forms, streamlining or de-escalation of therapy, dose optimization, and computer-based surveillance were listed as interventions that you might consider to add to your stewardship program. With the 2016 update, with the guidance from IDSA about implementing antimicrobial stewardship programs, the interventions or suggestions were broken out into 4 key categories. So we had interventions, which included some of those same things that we saw from that 2007 initial guideline. So we still have prospective audit and feedback and/or pre-authorization. We have our facility-specific guidelines, a suggestion to target patients with specific infections, intervene to reduce the use of agents associated with C. diff, encourage prescriber-led review of regimens through antibiotic timeouts or some other similar stop and review of different regimens, and then incorporation of clinical decision support. Other efforts were described under the optimization, diagnostic, and special populations. And I think some of the things that are found in the optimization area, such as penicillin allergy efforts, as well as pharmacokinetic dosing, IV to PO conversion. I think some of those optimization areas are definitely key places that you can look for enhancing your stewardship program and considering one of those priorities. So let's take a look at those core recommendations for pre-authorization and restriction. The 2016 guideline does a nice job of laying out the advantages and disadvantages of each of these actions. I think I want to call your attention to the fact in the pre-authorization or formulary restriction, some of the advantages of this include the ability to decrease the initiation of those unnecessary agents, because we know that once agents get started, it's a lot harder to take them away. And so having a pre-authorization or formulary restriction in place, stops that from happening in the beginning. And also the ability to decrease costs and quickly respond to shortages. However, disadvantages of pre-authorization and formulary restriction that I want to hone in are that it can be resource intensive, especially if you have some kind of phone call that has to be made or chart review that has to be done by the person who's doing that approval. And then also the effectiveness can be varied by the person who is doing the approval. And so you have some places where maybe things get through the cracks that you would not otherwise want to. In terms of prospective audit and feedback, advantages include increasing the visibility of your team. You're doing your feedback and calling teams or going on rounds to discuss your interventions, and you're getting that antimicrobial stewardship team right out there for everyone to see. Also, this can be flexible. You don't have to make your recommendations in the middle of the night. You can do it during daytime hours. And in resource limited settings, it doesn't have to be completed every day. It can be 3 times a week or twice a week. So those are some great advantages. However, if any of you have ever conducted prospective audit and feedback, you know how labor intense this can be, and often feels like you're looking through, depending on your bed size, many patient records in order to find a single intervention. And we'll talk about some ways to enhance that later on, but just kind of thinking about that, how labor intensive it is, are there other things that you can do at your program that maybe gets you a bigger bang for your buck? So let's go back to the basics of IV to PO or intravenous to parenteral conversion. I know that as a student pharmacist and then a pharmacy resident, this was something that was part of my routine day-to-day activities, not just for antibiotics, but for other medications that patients were taking in the hospital. And just to review, the benefits of converting patients from IV to parenteral routes include decreases in length of stay, cost reductions, the avoidance of complications associated with those intravenous lines, improving patient and nursing satisfaction. I think there's a great study out there that talks about how fast it is for a nurse to give an oral medication compared to an IV medication, and just the time that is saved by changing the route. There are no adverse impacts on efficacy or safety that have ever been seen, and it can be implemented in any setting. This is a pretty low-hanging fruit intervention that can be implemented in any setting. On the right-hand side of the slide are some suggested criteria that you might consider when converting patients over to oral therapy. Can they tolerate and absorb that therapy? Are they clinically stable? Do you have source control? Is there actually an oral regimen that exists, and has susceptibility been confirmed? And I think importantly, are there any patient level or psychosocial or economic factors that require IV therapy? And then lastly, is there likely pharmacokinetic, pharmacodynamic target attainment? So take these factors into consideration when you're thinking about your own IV to PO program or implementing an IV to PO program. And you may be asking yourself, we've been doing IV to PO for years and not really sure if it's beneficial. So what data is there to support IV to PO conversion? There was a great study published earlier this year in 2024 coming out of the Medical University of South Carolina. It was a retrospective study evaluating the impact of an IV to PO conversion at 7 community hospitals. So I love this study because although conducted by an academic institution, it was conducted in a community setting, which I think really speaks to a lot of people because not everybody works at an academic facility. What was done in the intervention was an IV to PO list was constructed in the EMR, focused on 9 agents that have good oral bioavailability. Patients would land on this list and alert pharmacists to the potential opportunity for an IV to PO conversion. And then in Region 1, oversight of this program was by an ID trained pharmacist. And in Region 2, it was conducted by a non-ID trained pharmacist. And what they found in their outcomes is that in both regions, so regardless of whether there was an ID pharmacist providing oversight, there was a decrease in the mean days of therapy for IV usage and a concurrent increase in oral usage. And additionally, in Region 1, where there was that ID pharmacist oversight, there was a decrease in mean days of therapy of total antibiotics. So these are really exciting outcomes. We're seeing some decreases in antibiotic usage, which is what we're wanting. And the key points I think coming out of this study are the need to leverage your EMR to help you hone in on who these patients are that might need this intervention. That can be as simple as just a list of all the patients on, a specific antibiotic. It doesn't have to be complicated, although complicated systems do also exist. This also highlights how useful this can be even with limited resources. So, they had the one region where there was an ID trained pharmacist and another region where non-ID trained pharmacists were doing this. The other thing I think is so important is they were able to advocate for additional positions with the cost savings from this study. So combined across both regions, I think they saved something like $25,000 from this intervention. So this is a great study to demonstrate that IV to PO can help you with cost savings and decreasing your antibiotic use. What about other types of antimicrobial stewardship interventions like de-escalation and streamlining? I know that de-escalation is a key part of a lot of prospective audit and feedback, and there's lots of different types of de-escalation. You could be suggesting narrowing the spectrum from a broader spectrum agent to a narrow spectrum agent. You could be decreasing the duration of therapy. So by recommending, an appropriate therapy duration for a particular infection. Also changing from IV to oral, which we just talked about, could be considered de-escalation or streamlining. So thinking about that, what data is there to support de-escalation and streamlining that it actually makes a difference? So the Simplify trial, which was an open label, pragmatic, randomized trial conducted in 21 Spanish hospitals, really set out to give us some guidance and evidence about de-escalation and its impact. They looked at patients with bacteremia caused by Enterobacterales susceptible to a de-escalation option. In their groups, they were randomized to either the de-escalation group, and there were 171 patients in that group, or the control group, which had 173 patients. The outcome they were interested in was clinical cure 3 to 5 days after the end of treatment. And what they found was that 90% of that study group, so that de-escalation group, versus 89% of the control group had clinical cure 3 to 5 days after the end of treatment. There was no difference. So their conclusions were that de-escalation was non-inferior to continuing therapy, and there was no increased risk of adverse events. So this is really great. This is giving us that data that we need to go back to our facilities and say de-escalation is something we might consider focusing on. It's non-inferior and it did not increase adverse events. But what other data is there to support de-escalation efforts? This study was conducted in the United States as a retrospective cohort study at a 1,300-bed academic hospital. They looked at all patients greater than or equal to 18 years who had sepsis, severe sepsis, or septic shock that were administered at least 3 consecutive days of beta-lactam antibiotics. And they used an antimicrobial spectrum score, which gives you a numerical score based on the spectrum of the beta-lactam antibiotic. Their patients were divided, again, this is retrospective, so they grouped their patients into 3 groups. The biggest group was the no change group at 62%. 20% of patients were de-escalated, and about 18% of patients were in the escalation group. What they found, and they were really interested in, was the onset of new gram-negative resistance. They found that 8.3% of all patients developed new gram-negative resistance. And that was with 644 out of their 7,742 patients. But what was really key was that there was a reduction in the development of this resistance in the de-escalation group compared to the no change group. So this is the data that we've been all, hoping for and looking for, is that de-escalation actually does impact antibiotic resistance in a pretty sick patient population. So this is a great place to maybe look for an opportunity at your program, looking at that sepsis patient population, which we know is, a key goal that our healthcare facilities are working on, and then using de-escalation in these patients with the hope of reduction in antibiotic resistance. So hopefully I've given you a few ideas and some data to support those ideas, to go back to those basics, whether you want to revitalize your prospective audit and feedback, or maybe you want to implement a formulary restriction process, or maybe you're really excited about the data like I am for IV to PO conversion and de-escalation. Consider how you can implement these into your program for 2025. With our remaining time today, I'm going to talk about our third area for priority, and that is embrace your technology, or if you're in a technology limited area, enlist the support of your friends. And we're going to talk about how these technological interventions can help your stewardship program, as well as how enlisting the support of your colleagues and trainees can support your stewardship program. So for those of us that do have an electronic health record, or maybe are implementing or developing an electronic health record, we sort of have, from low-hanging fruit to really complicated interventions that we can leverage our electronic health record to help us with. So at a very generic level, we can require indications when placing an order in the health record. That's a pretty easy, I'm not a technology person, but a pretty easy win that most, I think, EHRs will allow you to do. Next, more complicated is incorporating your guidelines into the EHR. And that can be from a more basic level all the way up to a really complex, order set within the EHR level. And then lastly, we can use the EHR in a very complicated way to incorporate smart prompts that are patient specific that help guide providers to pick the right antibiotic. And so we're going to walk through some data to support each of these different interventions. So looking at the requirement of indications in our electronic order set, this is a single center study conducted in a children's hospital in the United States, looking at the impact of indication-driven order entry on prospective audit and feedback. So they were trying to decrease the amount of prospective audit and feedback that their pharmacists needed to do, which is an amazing goal to set out with, right? And so what they did is they implemented dose regimen recommendations based on the indication that was selected at the time of order entry for 3 agents: cefazolin, piperacillin tazobactam, and meropenem. And what they found was that overall, the percent of prospective audit and feedback decreased from 34% in the pre-intervention to 22% in the post-intervention. And so incorporating this indication-driven, dose regimen recommendation meant that their pharmacist didn't have to do so much behind the scenes to intervene and get these doses correct. They were correct from the beginning. So think about ways that you could leverage your EHR to work in a similar way to decrease your efforts on the backside of that prospective audit and feedback. What about guidelines? This was a really great study published in May, looking at the impact of antibiotic order sets on the standardized antimicrobial administration ratio, or SAR. This was a 5-year single center quasi-experimental study. They actually had 5 phases. Phase 1 was the pre-intervention phase, and then phases 2 through 5 were took into account months of the year that did not include June and July, so they could take out those months when they had new trainees and a lot of turnover at their facility. Importantly, these 5 years, especially years 3, 4, and 5, included COVID pandemic years. So they were able to keep this intervention in place throughout those years. What they did was they implemented order sets in their EMR for common infections. And what they found were decreases in their SAR from phase 1 to phase 5, that's just statistically significant, a statistically significant reduction in days of therapy, and as well as a reduction in fluoroquinolone and clindamycin orders. Interestingly, in phase 5 of this study, they added education to this intervention. And so they reminded providers that the order sets existed in the EHR, because if people don't use the order sets, they don't help you. And so that was another intervention that is added on top in that 5th year. So think about how your guidelines live right now. Are they on paper? Are they on an external platform that people have to go look for them? Or can you incorporate them into your EHR and get this big win? I've heard other people around the country talk about, yeah, we have our guidelines in the EHR, but no one uses them. So again, consider that educational component that you might need to add to get people to use your guidelines. What about those more complicated interventions? I'm sure many of you are aware of the INSPIRE trials that have been published over the course of the last year. And so these trials were conducted at HCA, which is a very large healthcare system here in the United States. The pneumonia and urinary tract infection trials were conducted in, I think, about 59 of the HCA hospitals. And then the skin and soft tissue and abdominal trials, which were just presented at ID Week, were conducted in around 90 hospitals across the HCA system. These studies all had the exact same intervention. They were just conducted across different disease states. So they implemented a computerized physician order entry bundle versus routine antimicrobial stewardship on antibiotic selection during the first 3 hospital days in non-critically ill adults greater than or equal to the age of 18. The CPOE bundle included routine antimicrobial stewardship efforts plus smart prompts from the EHR for patient-specific organism risk, appropriate antibiotic choice recommendations, and then they encouraged providers and gave them feedback about how they were doing. The routine AMS group also got a lot of great tools that probably many of us are doing. They got educational materials, coaching calls, hospital guidelines, protocols. They had to document indication, and then prospective audit and feedback occurred as well. And what they found across all of these disease states was a pretty substantial reduction in that empiric extended spectrum duration of therapy, anywhere from around 17% all the way up to 35%. So these are just fantastic outcomes that they found using this smart prompt. But as I mentioned, this is probably the most complicated type of intervention, and it is going to require a lot of support from your IT team, and you're going to need people to help you incorporate this, because you've got to do a lot of work up front to identify what these patient-specific risk factors are. Additionally, if you have something like this embedded into your EHR, it can only account for the information that's in your EHR when it's looking for patient-specific risk. So if your patient presents to your hospital from another hospital, it's not going to be able to see that, they had MRSA at the last hospital. It's only going to be looking at your hospital. So we need to make sure providers understand that they still need to, have that clinical decision-making and be aware of those limitations. Just as an example, this is what the smart prompt might look like. So an extended spectrum antibiotic is ordered within 3 days of admission, and that triggers the prompt. If the patient has a multi-drug resistant organism risk greater than or equal to 10%, the order will complete without any additional screens. So they'll process the order as usual. If their MDRO risk is less than 10%, then the prompt is going to recommend, in this case, and as an example, if they've ordered cefepime, it's going to recommend ceftriaxone. And then it's going to subsequently say this patient's risk of Pseudomonas UTI is less than 10%. And it's going to allow the provider to cancel the order, override the order, or replace the order, or accept the recommendation for ceftriaxone. So this is a really neat tool. I encourage you to check out these studies and listen to, if you have the opportunity, to listen to the presentations from ID Week or one of the Society of Infectious Diseases pharmacists' recent Breakpoints episode included one of the authors from this study. If you have the opportunity to look into those, I encourage you to do so. And if you work at a place, if you're lucky enough to work at a place that has the infrastructure to make this happen, this is really amazing, because this works and it doesn't require a human to intervene. This is happening at night. It's happening on the weekends. It's happening during the COVID pandemic. And so this is a really great tool if you have the ability to implement it. But some of you may be saying, like, I don't even have an EHR, or I don't have the IT infrastructure or resources to have this happen. And so for you, I would encourage you to enlist the support of your friends and your colleagues to help you carry out your antimicrobial stewardship efforts. There's a lot of data that says having an ID trained pharmacist and ID trained physicians is instrumental in antimicrobial stewardship programs. But pharmacists who are not trained in ID can be helpful in stewardship efforts. And there are training programs that people can complete. I talked about those last year in our webinar. So if you're interested in learning more about those, we can get you that information. But there are training programs that people can complete to become more up to speed with antimicrobial stewardship efforts. I would also encourage you to reach out to those providers in your facility, the hospitalists, the surgeons, your pediatricians, your internal medicine and family medicine physicians. Get them on your team, bring them onto your stewardship committee, have them at the table when you're making decisions about what agents you're going to use, what your order sets are going to look like, what your dose recommendations are going to be. When you get those people to have buy-in from the very beginning, they can go out and be your champions across your health system. Also think about your nurses, your microbiologists, other departments. So, I talked a little bit before about how so many of our antibiotics get started in the emergency department, and then it's hard to get them stopped later. Try to incorporate antimicrobial stewardship in those folks. Bring them to the table and have them participate in your conversations. Advanced practice providers as well. And then your trainees, your pharmacy students, your medical students, your nursing students. What can they do to help you? And so I took the opportunity to look into the literature to find any evidence about using trainees for antimicrobial stewardship efforts. And I found a couple of studies that I wanted to share with you today as we come to the close here. The first was a single center retrospective chart review, and the intervention was prospective audit and feedback by an ID pharmacist with pharmacy students and without pharmacy students. And what they found was that total interventions were higher with students versus without. And I agree, when I was practicing and had students on rotation, we could see so many more patients because there were 3 of us looking at all of the patients that we needed to look at for that day. Now, the key point coming out of this study is that students can help increase the number of those daily interventions because they can be looking at patients while you're doing your other activities. The other study that I pulled for this that I wanted to share with you was a single center retrospective study. And this intervention was a 2 to 4 week antimicrobial stewardship prospective audit and feedback elective offered to 4th year medical students. And what this study found was that students offered a suggestion for antibiotic optimization in 54% of the patients that they assessed. Now, while this study wasn't really looking at using medical students to augment your antimicrobial stewardship efforts, what they did, find in their discussion is that students learn appropriate prescribing practices for the future. So we're kind of getting them ready to go on to that next step when they're going to be residents and practitioners. And so this is kind of like a different take on that same idea of incorporating trainees into your program. So consider that trainees, other pharmacists, are there other people that you can engage to help you in your stewardship efforts? So with that, embracing your technology and enlisting the help of your friends was that third key priority that I want you to think about for 2025. What opportunities do you have in this area to improve your antimicrobial stewardship program? In summary, I hope that I've convinced you that establishing a baseline of what's going on at your facility can help you find that focus that you're looking for and that opportunity to improve antimicrobial stewardship at your facility. I also hope that I've given you some evidence to support some of those efforts that you're probably doing day in and out and unsure of whether they actually make a difference. So we looked at IV to PO conversion and de-escalation opportunities and how those can provide gains. I think it's especially so exciting to see that de-escalation in the single center study led to a reduction in antibiotic resistance. That's great as we're observing Antibiotic Awareness Week. And then lastly, I've given you some nuggets of information about how you might incorporate technology to enhance your antimicrobial stewardship program. And for those of you that maybe don't have those technology resources available to you, who are those colleagues that you can identify to add to your antimicrobial stewardship team and to help you in your efforts at getting every patient on the right antibiotic therapy? And with that, I will stop, and I think I've left us about 10 minutes for questions and answers, so we're happy to take any questions you might have.
Thank you, Anne. We've got one question here. They say, what do you suggest as antibiotic stewardship in surgical hospitals when 99% of ABX usage is prophylactic? Other than reviewing for appropriate doses, allergies, etc., it is difficult to have a robust program.
That is such a great question. And I think you hit some of the opportunities in your question there. But I think one of the things, particularly for surgical infection prophylaxis, is not just reviewing doses and allergies, but what can you do up front? Particularly around penicillin allergy. So we know that so many people across our patient settings have a listed penicillin allergy, and so what can you do in terms of either delabeling that penicillin allergy or at the very minimum, talking to patients to verify that allergy and get it narrowed down as much as you can? There was a great webinar yesterday about penicillin allergies that was put on by ASHP, and they talked about how they did penicillin allergy delabeling at Vanderbilt University, and there's some more data coming out about that hopefully in the next year. But I would really encourage you to take a look at that opportunity to upfront get patients on those narrow spectrum agents. And then secondly, I would think about, and I don't know your setting and how long people might stay post-operatively at your surgical hospital, but thinking about reduction in those post-op antibiotic days of therapy. So I know that's a fight a lot of us still are trying to fight, cefazolin times 48 hours or 72 hours, reminding people that the guidelines recommend no antibiotics after the incision is closed. So focusing in on that days of therapy. And then very lastly is what can you do around that transition of care? Because I think a lot of people might get sent home on antibiotics. So is there anything you could do there to intervene to say that antibiotics aren't needed, or to, at a minimum, get people on the right duration for those outpatient antibiotics? So hopefully that gives you some ideas of where you might go for that.
We've got another question here asking about indicators. How do you measure your interventions?
Yeah, this is such a great question, and there's so many different ways that you can look at your interventions. So a lot of people track interventions in their electronic health record. So that's one way, and then you can run a report of all of those interventions and look at the acceptance rate. So one of the platforms that I was familiar with, you would say whether the provider accepted or rejected your recommendation, and so you can gather that data. Before I had access to a system like that, I kept track of my interventions and in a a spreadsheet, and so that's another way that you can do it. It's very time consuming, and you have to remember to go do that, but that's another way. And then at the bigger global level, if you implement one of the IV to PO conversion, or maybe some structured de-escalation, doing that before and getting that baseline, and then doing an after and getting that post data, then that gives you some information about, am I seeing a reduction in my days of therapy? Am I seeing people accepting my recommendation? So those are a few ideas of how you can go about looking at how your interventions have an impact.
We've got another question here. What is the best way to share antimicrobial use data to ordering providers?
Yeah, that's a really great question. And I know we would all love to be able to share data with them that's specific to them. And I know sometimes that can be hard. It depends on your technology availability. But I think getting the word out in weeks like this, and whether you've got an intranet, whether you've got a platform where you can send out announcements, and just sharing your annual data, maybe if you're using the National Healthcare Safety Network and you're getting your antibiotic use data, showing your standardized antibiotic administration ratio over time, or your days of therapy over time, is one idea. Another thing you can do is going to these individual meetings. So, your internal medicine section meeting, your hospitalist section meeting, your ER meeting, and sharing with them data out of their group is another great way. I know in my previous role if we conducted a medication use evaluation and it found that we had an outlier in a particular area, we would take that to, the chief of that area and discuss it with them. And sometimes we would go to a meeting and never call anyone out by name, but, just show like, look, your prescribing is much higher than others across the facility. So those are a few ideas that I have. But I'm sure there are many other ways. I know a lot of people have dashboards, and there's a lot of great work being done across the globe for sharing that antibiotic use data with providers.
Got a question here. In my hospital, we really struggle with antibiotic prophylaxis in surgical patients. We've tried to convince surgeons about the importance of reducing the incorrect use and duration of antibiotics with little success, even with the evidence and data. What approach would you recommend, or what article could I share with them?
Sure, that's a great question. And I'll start with the second half. What article could you share? And that one, I'm just going to say right off the top of my head, I don't have a citation that I would go to besides the national guidelines that are available on surgical infection prophylaxis. One thing I know in the United States that surgeons sometimes hesitate is that often those guidelines are coming out of the Infectious Diseases Society of America and the American Society of Health System Pharmacists, and not directly from those surgical infection societies. So when you have the opportunity to go look for surgery specific guidelines that are coming out of those societies, that's what I would encourage you to do. I know like the American Urological Association has their own guidelines, and I was able to take those directly to urologists and say, look, your own guidelines say this, so let's work together. And that's the other thing I would say is the approach is let's work together. Bring those people to the table. Can you get a small win? Can we decrease it from 72 to 48 hours post-op? Can you get that small win first and then just keep having that conversation?
And I think that's it for our Q&As.
Thank you. And thank you everyone who joined us today. I hope you continue to go out and fight the good fight and work together to improve antibiotic use and antibiotic resistance.